Hello, students. Today's lecture is on Chapter 59 from the Modern Dental Assisting Textbook, Edition 13, and the title is Dental Sealants. I'm Dr. Samara Rashid. Okay. And we are going to go into some learning outcomes. We want to talk about some of the key terms that are listed in the textbook. We want to also talk about the factors for sealants, the types of sealants, what are the methods of polymerization of the sealants, the criteria and when do we use sealants, and we also want to demonstrate skillful sealant placement. Dental sealants represent one of the greatest advances of modern dentistry, and the purpose of a dental sealant is something where we want to prevent dental caries in pits and fissures. So if they're in pits and fissures, they're only in posterior adult teeth. Dental sealants cover most often the occlusal, buccal, or lingual tooth surface and prevent bacteria and food particles from settling into those pit and fissures of the tooth, causing tooth decay. So we don't want them to cause tooth decay. So if we have the sealant on them, we could prevent such a thing from happening. So pits and fissures, they're really narrow. As you could see here, you could see a cross section of a tooth, and then you'll see the bristles of a toothbrush. Here's the rather a I don't want to say a pit, but kind of like a fissure. And you could see that even the bristles of the toothbrush cannot even reach the groove here. So those pits and fissures are quite narrow. And they're just the perfect spots for bacteria and food to have a little bit of a party in there. So sealants act as a physical barrier that seals those grooves. They then create this smooth surface on the tooth, and they prevent food and bacteria from getting into those small spaces. Here's another cross section of a tooth. So you could see that no matter what, you could see that tiny little space here where the fissure is, you could see that there is debris present in that tooth. And here's an example of a sealant that is placed in a posterior tooth. It looks a little milky and it's hardened. They do come in different colors, but it's usually clear or milky is the popular color. And when you rub your tongue on this, right, if you got a sealant, they feel very, very smooth, almost like a skating rink. So whenever you see pediatric folks, like little children, come in, we'll say, "Hey, we're gonna get sealants in it." It's like, "Oh, what's that?" And then you're just like, "Well, that's like when I put a little skating rink on your teeth or on your posterior tooth or the teeth in the back." So there is a possibility that even after you clean a tooth and before you place sealants, that some bacteria could be present. But research shows us that if you put a sealant properly, it could eliminate the spread of that possible decay because the bacteria do not have any more nutrients getting exposed to it because they're walled off because a sealant could be placed. But a large carious lesions on teeth, obviously they should not be sealed. The most beneficial placement of sealants is during cavity prone years, and the cavity prone years are ages 6 years old all the way to 15 years of age. What are the indications? Just like what we talked about before, you got these deep fissures and grooves, newly erupted posterior teeth, or within 3 to 4 years of eruption, mostly children, but some adults could benefit from the sealants, and occlusal surface is present. That's when you can place a sealant, not an incisal surface. What are the contraindications? When do you not place them? Well, if you don't have pits and fissures, obviously, there's obvious occlusal decay. There's obvious interproximal caries that are in between. Let's say there's no cavity on the occlusal, but you have a cavity on the mesial or the distal, and the x-ray shows it. Then that would not qualify for a sealant. Okay. Insufficient eruption of the tooth is not completely erupted. Maybe there's a primary tooth that's about to be lost. And if it's about to be lost, there's no point in putting a sealant on. And you basically have poor patient cooperation. That's when they do not qualify to have a sealant on them. But what are the types of sealants? There's a wide variety on the market, but no matter what, the characteristics you want to consider for having a good sealant, first of all, is the method of polymerization. How is that sealant hardened on the patient? Are we using a light? Are we not using a light? Do we have to mix something? Okay. What about color? What about the fillers? What about the working time? How long do I have until that sealant hardens? Because I may have a patient where it's so hard The tongue is all over the place. So I need that working time to be very low. Placement technique. Does it have to be completely free of saliva? So these are things to consider. So what are the methods of polymerization? We say it here, the method of the polymerization. There's self-cured and there's light-cured. So with self-cured, it's a two-part system. You have a base and a catalyst, kind of like temp bond or kind of like IRM. Go back to your dental materials lab and you'll remember when you mix the two, you got a catalyst and a base. And then when they're mixed together, they quickly harden. That's self-cured. But light-cured, there is no mixing involved. And this is the most popular. After the material has been placed, it hardens during exposure, during when it's exposed to the curing light, just like composite. You also want to consider the color of the sealant material. Sealants may be clear, they could be tinted or opaque like white, like you saw in the previous slides. Tinted or opaque are more popular because they are easier to see and different from the tooth color. I don't know, in the practices I've been in, clear has been the most popular, but here I'm assuming they're referring to pediatric offices, tinted or opaque are more popular. I'm not sure. But I would go with what this says right here, that tinted or opaque sealants are more popular because they are easier to differentiate from the tooth, but they're not as desirable to a patient, especially nowadays, because everybody wants tooth colored stuff. Nobody wants anything more apparent. So in future visits, it's easy to check the retention of a sealant if you could tell if it's there. Some brands have a tint that it's visible during the application, but it's clear when you polymerize it. Now, some have fillers in them. Some are filled and some are unfilled. So, filled or unfilled, these are considered additional materials that are in the sealant material that could kind of prevent it from being worn down. So, the filled sealants, some dentists think that there's less wear on the occlusal surfaces, but you got to check for the occlusion, right? That's something that's really important because that sealant is not going to wear down as much. Whereas if you have an unfilled sealant, right? If it's an unfilled sealant, then you really have to make sure your occlusion is perfect, or else you're going to get a phone call later saying, my teeth, it feels like it's uneven, or my daughter's teeth or son's tooth is uneven. They had pain all weekend, then you're doing more damage than good. So you have to think about that. And not for nothing, but the fillers, they have to be equally resistant to micro leakage as well. Because if you have micro leakage, a leaky sealant, it's going to fail. You're actually doing more damage than good. Okay. So when the slide, a couple of slides before, we talked about working time. Self-cured sealants, that's the one when you have the base and catalyst. They polymerize to a final set within approximately what, 2 minutes from the start of mixing them. So you got 2 minutes to hurry up. The light cured material has the following advantages though. A curing light is used to harden the material, okay, to that blue light. It doesn't require mixing and it allows the operator to place and cure that material when you're ready, when the operator is ready. Okay. So let's talk about the pluses and minuses. So you have this table here. So the pluses to self-cured, no curing light. Yay. You can work on several teeth at a time. So that is pretty good. The light cured one, though, the pluses to that, short working time, and it's not that thick. It's low viscosity. Then you have the disadvantages, which is the negatives of self-cured is temperature is in the room affects the working time. So if you have a warm clinic, the warmer it is, the faster it sets. Overall, it does have a long working time because you're mixing two materials and the viscosity increases as the time increases. It's starting to set. So it's difficult to work with. The light cured, the negative to that, the curing light is bad to your eyes. Okay. The curing light, at the expense of the curing light is in and of itself is a negative. And the curing light only cures the area to which it's exposed to. Ambient light in the room can actually harden the material as well. Okay. So you want to prevent problems with sealant. So we talk about etching with composites. You also have to etch with the sealant. So the etchant is a phosphoric acid solution. We talked about this in what, DNA 110, right? Dental skills, I believe, dental materials lecture. A phosphoric acid solution that creates microscopic undercuts in the enamel for areas of the sealant to flow into. And so you want to take care so much so that the etchant does not contact adjacent teeth or the soft tissue. Why? Because it's very acidic. First of all, it tastes horrid. It tastes like very sour orange juice. I mean, I tasted it once by accident because I was getting a sealant done and a little bit went on my tongue and it was quite horrific. So something to think about. We don't want to, etch other teeth that we're not working on because you're just exposing those areas unnecessarily. Block contacts. Let's say there's too much sealant material that you place and it went into the mesial and distal. Now you have to make sure that the patient's able to floss. You got to get that out of there. And then also bite interference. If the sealant is too high, the patient's bite is going to be off and they're going to have a lot of discomfort. And then failure itself. Most sealant failures will occur within 3 to 6 months. And if we were live, I'd ask what's the most common reason for sealant failures? Well, a lot of that is moisture control. It's hard to get, it's saliva free. There might have been contamination in there. Of course, there's other factors for sealant failures. Like let's say there was like a cavity we didn't know about that was underneath. And it was apparently there, like it was not necessarily deep, but it's there, and you're putting a sealant on top that could make it worse. But the most common reason is lack of isolation, moisture contamination. Here you could see excess sealant blocking from the contact area. The sealant went all over the place. Look at this in the interproximal area. So you got to get rid of that before the patient leaves. Here is this air abrasion tip that people use to kind of clean the tooth off. Remember that little nozzle here, and it kind of make abrades the tooth a little bit before you place the seal, or rather before you place the etch. Okay. Some brands of sealants release fluoride after you polymerize it. So there is fluoride being released from the sealant after it's cured. The theory is that the fluoride is released from the sealant creates some sort of fluoride rich layer at the base of the groove, and that helps with remineralization. Topical fluoride should not be applied to the enamel surface before a sealant is placed, okay? But it could be after you place the sealant, okay? Always follow the brand's instructions to see if fluoride polishing paste can or can't be used to polish the teeth, okay? How do you store them? Okay, so you got to replace the caps on the syringes, the bottles as soon as you are done. Don't expose the materials to high temperature. Do not store the materials in proximity to eugenol containing products. Most etchants and sealant materials are designed to withstand room temperature. Look at the brand's recommendations and the shelf life. Okay, the shelf life is usually what? At room temperature, it's 18 to 36 months. After that, it won't work on the patient. And some actually have to be refrigerated. Okay, but there are precautions that you must take when you're using an etch, just like you remember with composite. You don't want that being exposed to your eyes. That thing burns, or even to the patient's eyes or oral soft tissue and the skin. And in case of contact, you really got to flush out with water, especially if it goes in your eyes. So hopefully that never happens. You always have to wear eyewear um, because etching material has phosphoric acid. The sealant material, some patients are allergic to acrylic, so you can't use it on these patients. Acrylic can penetrate the gloves, replace if contact occurs. Okay. Here's some factors in sealant retention. Moisture contamination. That's the primary cause of failure because of sealant retention. So inadequate etching, you didn't etch it enough. Dental sealants have to be examined at each recall because sometimes they could break. A part of it could be lost. Partial, part of the sealant could be broken off. When dental sealants are placed properly, to be honest, it is not uncommon for them to last from 5 to 10 years. Okay. So expanded function dental assistants, they could do this. The surface to be sealed must first be cleaned with a rubber cup and pumice. No, fluoride is not preferred, okay? Retention of the sealant is then attained when you etch it with 37% phosphoric acid. Then after the etch, you want to rinse, dry, and isolate the field. So what are we looking for when we dry it? We're looking for a little bit of a frosty appearance, okay? And then you go ahead and apply the sealant in pits and fissures and the surrounding enamel and go ahead and cure it. Any moisture on the tooth could result in failure. I know I've repeated myself so many times. Moisture could come from saliva. It could come from the air water syringe tip that you're using that leaks water in, or even the patient's breath, believe it or not. If you suspect moisture, the sealant could be lost immediately or partially lost later. Also, leakage could occur around partially retained sealants, and then you get decay, and you actually do more damage than good in such situations. Here's a setup that you see. I mean, nowadays we have wireless curing lights, but this one was with the wire. But this is a curing light. You have the little shield to protect you with from the curing light. Your eyewear. You got your etch. You have a DAPA dish that you might need. Definitely the high suction, definitely the high speed suction. You got to need that occlusion paper. So some things are just not negotiable. Okay. So there's some things to think about. Again, you want to isolate and dry the tooth. Select the tooth, dry it. The surface to be sealed must be first cleaned with rubber cup and pumice. Pumice doesn't have fluoride in it. Doesn't have fluoride. Retention of the sealant is attained by etching that enamel. Etch it for 15 seconds, but not more than a minute. The sealant will not adhere. It won't stick if it's not etched properly. After you do that, use the HVE, wash and dry. Okay, isolation. That thing has to be dry. You look away and the patient like licked the tooth. There went your isolation and there it failed, and your frosty appearance will be gone. The tooth must remain dry. Okay, so dry for around 20 to half a minute, so 20 to 30 seconds. Then you want to check to make sure the tooth has that frostiness. Don't over dry. Now, we're not looking for complete desiccation, but we want to have a frosty appearance. Moisture contamination is the major cause of sealant failures. Go ahead, apply your sealant using the tip or a brush and only place it in the grooves. We don't want it swimming all over the place. Remember, a stream, not a river or lake. And you can use a clean explorer to move the sealant into the grooves. Cure each surface for 20 seconds. So some people, they place the sealant on the occlusal surface, like for example, on a mandibular, and they'll kind of drag it a little bit along the buccal groove. This is a maxillary, so it's not here. On the buccal groove of a mandibular to get to that pit right there. Okay. So you want to use Explorer to check the margins to make sure the sealant is adhered. So oftentimes when you're done, the dentist will come in, take an Explorer, and literally he or she will try to pop this off. You'll be like, what are they doing? I just carefully place that. But they have to do that. That is the only way to test to see this if the sealant has adhered properly. And they want to check for voids. So they're going to take the sealant and drag it along. So are you, to make sure everything is nice and like a skating rink, so to say. If not, re-etch it and apply additional sealant. And then in the end, after everything is cured, you want to check the bite, adjust it as necessary, and you cannot forget to floss. Then you can put fluoride if needed, topical fluoride, and you want to say all these things in the chart, all of these things in the chart, including the fact that you checked the bite. Okay. Thank you. I hope this helps. And thank you for sharing your time.